Hey folks, welcome to the AABIP podcast. This is Samir Al-Sarala from Case Western Reserve University School of Medicine in Cleveland, Ohio. I'm your host for today's episode. Thank you all for joining us today. It'll be a wonderful discussion about a condition that we won't see every day, but you may be called upon to assist with, pulmonary alveolar proteinosis. Today, we're very fortunate to have Dr. Tisha Wang join us. She's a clinical director and VP of the patient-based Pulmonary Alveolar Proteinosis Foundation and is chair of education committee for the American Thoracic Society. She's also a professor of clinical medicine in the David Geffen School of Medicine at UCLA and a clinical chief of division of pulmonary critical care and sleep medicine in the UCLA Department of Medicine. Welcome, Tisha.
Thanks, Samir. It's great to be on this with you. Thanks for the opportunity.
Awesome. Tisha, before we get started, do you have any relevant conflicts of interest to disclose?
I don't. I do consult for Partner Therapeutics and am a PI on a trial for PAP, but I don't think either one of those have relevant disclosures for this conversation.
Great. Just as a reminder, the views expressed on this podcast are those of the speaker in mind and not necessarily endorsed by the AABIP. With the formalities done, let's get started. So PAP is a rare diffuse lung disease that often presents with dyspnea and leads to respiratory failure. At times, bronchoscopic procedures are performed for the diagnosis and treatment. Although lengthy, a whole lung lavage can have dramatic impact on the patient's quality of life. Like many things within our field, there's variability of how this procedure is actually done. Well, let's find out more from our expert. Tisha, at your shop, how do patients with PAP typically end up on your radar?
Yeah, it's a good question, Samir. So, typically, in this area, I've become a known expert in this condition. So certainly in the Southern California region, and definitely at UCLA, if people get a diagnosis of PAP via biopsy or via a blood test, they typically get referred to me with a diagnosis. I often will also get queries on a regular basis from my colleagues and faculties, with CT scans saying, hey, Tisha, do you think this is consistent with PAP? What diagnostic testing should we pursue? And then honestly, across the country through the PAP Foundation and just a lot of awareness we've done on the internet, a lot of people actually now get referred to me from, I would say, even this region of the United States as a known PAP expert.
Sure.
So probably once or twice a month, I'll get a phone call from either a patient or a outside physician asking for advice on how to treat PAP, as I've, kind of gotten my name out there as someone who's very interested in moving this disease forward progress-wise.
So Tisha, this is, a fairly rare entity. I'm curious, how'd you get so tied in with PAP and what really started your career off with this?
This is a funny story. I could talk about this for 5 or 10 minutes, but, so I was a fellow at UCLA, and my program director and mentor actually had an interest in this disease. And so when I was in training, he trained me how to do whole lung lavage. And I was one of the few fellows that he actually trained to do whole lung lavage. And when he left, when I was a senior fellow, I basically adopted that position at UCLA where I was the one who knew how to do all the lung lavages. And I really liked the patient population. And during fellowship, I had a patient who was dying of this condition, needed a lung lavage every month or two. And she was around my age. And so I wanted to do something different to try to save her. And I went into the literature and actually put her on subcutaneous GM-CSF therapy. And she literally went from someone who was in a wheelchair needing a lung transplant to someone who was completely cured. And so then I became very interested in treating this condition with other sort of therapeutics. And when I was very young, a junior attending, actually, I got invited to be a rare lung visiting professor actually at the University of Cincinnati at their Rare Lung Disease Consortium, and met Bruce Trapnell, who's sort of the nationwide scientific expert on PAP. And so I just accumulated this patient population. I published on it. I perfected whole lung lavage. And then later on, actually found a patient partner here and kind of revamped the PAP Foundation. So it's been a long journey. I often talk about the long version of this story in grand rounds that I give, but it started when I was a fellow trying to save a patient who was my age who had this disease and needed a lung lavage every month or two.
Yeah, it's super interesting for these podcasts that we do, and I have the opportunity to talk to all these experts across the globe. And I call these I've coined these origin stories of where they get interested in their specific topics. So that's awesome to hear. Thank you for sharing with that for us. A common request in patients suspected to have PAP is for bronchoscopy. I think we can all agree that it's not always required. So for someone who sees these patients more frequently than I would say most of us do, what boxes need to be checked prior to a patient undergoing bronchoscopy for a diagnosis of PAP?
Yeah, I think a bronchoscopy with lavage is fairly low risk, and so I'm not opposed to doing it for most patients with PAP. But you can diagnose this with a simple blood test. I mean, the anti-GM-CSF antibody blood test is actually almost 100% sensitive and specific as a test for this condition.
Mm-hmm.
In fact, I just saw a patient probably in the last month who I diagnosed via the blood test, and actually he had such mild disease we decided to completely forego bronchoscopy at all. So it is something that you can easily diagnose with a blood test if you have clinical suspicion. I think if you do a bronchoscopy, which again I'm not completely opposed to it, all you really need to do is a BAL and send it for cytology for sort of the PAS staining to get a diagnosis. I don't think most of the time you need biopsies, and certainly you don't need surgical lung biopsies, but people forget, I think, that this is as simple as being diagnosed on a blood test that you can send to, in the US, you can send it to University of Cincinnati, or you can send it to National Jewish. So it is a send out, which I think is a little bit more of a barrier. But otherwise, it's a test that's 100% good, basically, for this condition.
Yeah, you don't see too many tests with that degree of percentages as far as specificity is concerned. I typically have been approaching these cases about doing the bronchoscopy to help rule out other things or see if there's anything else going on in addition to getting these tests kind of going. Is there any scenario in which you would consider surgical lung biopsy in these patients?
Samir, in my entire career of managing dozens and dozens of PAP patients and giving advice, I have actually never requested a surgical lung biopsy for the diagnosis of PAP. So if you look at PAP as a syndrome, about 90% of them are going to be autoimmune PAP. And that is what that blood test is 100% good for diagnosing that 90%.
Mm-hmm.
The vast majority of the other cases are going to be secondary PAP, and you can usually find, an etiology for that. Do they work, with silica? Do they have myelodysplasia syndrome? Do they have an immune deficiency? So you almost never need one. Now, if you look at the PAP registry, the research registry we set up with Cincinnati, 2/3 of the patients actually had a lung biopsy during diagnostic workup. About 40% had a surgical one, about 40% had a transbronchial, and actually 10% had both.
Sure.
The important thing here is that 10% of those biopsies didn't even find PAP. So again, if you have a population of 100 patients and 90% of them you can get with a lung biopsy, 90% of patients you can get with the testing, with the blood testing, you're really only left with 10%, and probably of that 10%, 9 out of 10 you can find a secondary etiology. So again, I've never actually sent someone for a surgical lung biopsy. I think if I felt like I needed a biopsy because it wasn't autoimmune PAP, and I couldn't find a secondary cause, I probably would favor a transbronchial or even a cryobiopsy, even though there's not a lot of good data before getting a surgical lung biopsy.
At your shop, is there some sort of MDD for patients with PAP, or they all come through you? You have a specific template you go through and check all the boxes and get them on the right therapy?
That's a great question. We have an MDD for our interstitial lung disease program, which sometimes I think patients can actually go through with features of PAP, in which case I'll participate. But most of the time, I just get sent, an email or even a picture of a CT scan asking me if I think this is consistent with PAP. And again, it's so easy for us to send a blood test that oftentimes I'll just, help them send a blood test. And if the blood test comes out positive, there's your diagnosis. You don't have to do anything more. Or sometimes I'll say, well, maybe you want to rule out infection in this case because of the clinical scenario. Maybe you want to look at, malignancy, et cetera, et cetera. So there's not an MDD as much as it's just a consultation through, through me. I have another sort of expert here. Her name's Eleanor Lee, who also sees these rare lung disease patients at UCLA. But very occasionally we'll go through the interstitial lung disease MDD.
Sure, makes sense. it's probably the best MDD that fits into, so it makes sense. So are you the only one doing whole lung lavage at the UCLA hospitals?
I trained Dr. Eleanor Lee, who's kind of my scientific counterpart. So she's an MD PhD who does research in PAP, but she also has been trained in whole lung lavage. But yeah, I always joke that the interventional pulmonologists have it nice at UCLA because I do them all. I do train when possible the interventional pulmonary fellows to do it. But I think when we built an IP program, I had already done hundreds of lung lavages here. And so I just kind of kept it under my shop. And honestly, with a lot of people nowadays on clinical trials or therapies, we're not doing them as frequently as we used to. I used to probably do 1 or 2 lung lavages a month. And now it's probably, 1 to 2 lung lavages every quarter or 2, So the volume has gone down quite a bit.
On the rare end of procedures, indeed. So Tisha, walk me through your lavage process. Everyone does it differently. I wanna pick your brain of how you're doing it there.
Everybody does do it differently. There was even a paper saying that everybody does it differently. I have refined the process a lot over the years, and have gotten a lot of input. Actually, there was a guy in Denver and actually a physician in the UK that had probably the only 2 people in the world that I ever met that had done more lung lavages than me. So I asked them for their procedure as well and tried some of their tips. But this is kind of what I've landed on. So infusion via gravity,
Okay.
Removal of the fluid through suction, through wall suction, which I know is not always done, but I've tried to remove it via gravity and remove it via suction. I think suction actually works better, and I've never had a complication from the suction itself. Double lumen ETT with a lot of care to get that double lumen ETT in the right place and very secure. So I'll be frank with you, I only will agree to do this with very specific thoracic anesthesiologists at UCLA because it is, most of the time it's semi-elective. We use warm saline, so the patients will get hypothermic. We use a bear hugger. I use a Foley because I give them Lasix at the end to help them extubate, which has actually worked quite well. I do not use any type of hemodynamic monitoring, so they don't need an arterial line or anything like that. Patients are kept flat. I have sometimes used a pneumovest if they're stable enough, meaning that, again, the thing I worry about moving them too much is that ET tube being dislodged, which is the worst thing that can happen during a case.
Yep.
But if they're stable, I'll have the pneumavest turned on actually during the procedure. And I basically keep track of what, goes in via our 3-liter bags. We put in, probably anywhere between 800 cc's and a liter for each fill, 1 lung at a time, suction all the fluid out, again, via suction. And then every 3 liters or so, we have the canisters, we line them up like the classic pictures that you see on the internet. And when the fluid is clear, which can be anything between 15 and 40 liters, we basically keep track of all the fluid that we've drained out by suctioning it up via a Neptune, and we calculate what went in and what came out, basically. So I always do 1 lung at a time. I've actually never done 2 lungs in 1 day. I used to try doing it on consecutive days, but funny enough, I found that they did better when you just let them completely recover, because obviously they're gets worse before it gets better, and then you have to ventilate that lung. So I usually send them home often on the same day. So oftentimes I'll bring them in at 7 in the morning and they'll be home by the afternoon. If the patient's very sick on oxygen at baseline, I'll actually keep them in house to diurese them overnight. But otherwise, a lot of the patients are now sort of outpatient procedures. You start in the morning, and then I will bring them back for their other lung in 2 to 4 weeks. And occasionally they'll actually tell you they're doing so good they don't even want the other lung washed out. And so sometimes you end up just washing one out, and then you're good for months to years.
So what made you kind of decide on gravity to get the fluid in? Have you used a rapid infusion in the past, and gravity just seemed better? I'm curious to hear your thoughts.
We've actually never used the rapid infusion. I guess I'm not in theory against it, but the gravity thing that we set up is actually really fast. Like, we set up pretty large tubing actually. And so I guess it's never really slowed us down. And so I never really even thought to use a rapid infuser. We're able to finish a case really pretty fast here. So I think from, as long as the patient's completely anesthetized and we start filling, it probably takes about 90 minutes, maybe 2 hours to do a case.
Okay.
So it hasn't really been an issue with timing, as long as we, again, suction out the fluid via wall suction. So, but that's an idea. That's something I've never actually considered and would be willing to do if it really is much faster. But we don't find the gravity system. You just put the bags really high up on these IV poles, and it usually flows in very quickly.
Sure. With the double lumen endotracheal tubes, are these the traditional ones, or some of the newer ones that have the camera that you can see the airway?
They're the traditional ones. Obviously, we have a scope with a camera in the OR, but no, they're the traditional ones. Interestingly, our anesthesiologist is trying to design one that actually works much better, because we do a whole lot of whole lung lavages, to be a little bit more, I think, sturdy. But I think that we've been just using the old fashioned double lumen ET tubes.
So that process, I can relate to most of those things. It sounds fairly typical to what I learned to do during training, with some differences about, if the patients stay overnight, get lungs done on back-to-back days versus going home and coming back later. What are your thoughts on sequentially lavaging segments with a traditional bronchoscope? I've seen that done from time to time, and by seeing, it's reports done at referring institutions. What are your thoughts on that?
There's a few case reports. I've thought about it in ICU patients that are really sick, and you worry about taking them right down to the operating room, putting them in our general anesthesia, and then completely only ventilating them on one lung. But I've not gone past thinking about it. In fact, I was talking with my interventional pulmonologist about a case, and I was like, oh, maybe I'll try this thing in the ICU where you just do sequential lavaging. And I think her comment to me was like, I'll see you tomorrow, because you're still going to be at the bedside lavaging the segments. And so I think it probably would be time consuming, but I guess I've never had a situation where, and I've had patients that are, intubated with this, that get brought from outside hospitals, where we were unable to lavage one lung in the traditional way, which I think is more efficient and probably more high yield. You can probably get more thorough washing with the method that we use in the OR. Oftentimes what we will have to do with those really sick patients is just ventilate them on both lungs in between the fills, which does make the case go on longer.
Sure.
But I think if your back's against the wall and you have a really sick patient in the ICU, I'm not against doing the sequential lavage. I think it really is just an efficiency issue.
So kind of talking along the same lines, with patients that are potentially in the ICU and very ill, what are your thoughts on doing this on someone on VV ECMO support?
So there was one patient actually who was so sick, ventilated in very high settings, where I actually called ECMO again as backup. Before I even went into the OR. Thankfully, we didn't have to use it. And so I think that if you absolutely needed to do it to save a patient's life, I think absolutely you should do it, because the patients will improve with whole lung lavage pretty quickly. With that said, we've been able to do these really sick patients with the method of fill, empty, ventilate, fill, empty, ventilate. And again, you just get into a rhythm, and it does make the case probably twice as long. But perhaps, having a 4-hour lung lavage where you have to ventilate in between, every 1 to 2 fills is probably better than putting someone on VV ECMO. So again, we've never had to do it, but I think if it was life or death, I would absolutely support doing it.
And asking you, since you have a lot of experience with this procedure, what are your thresholds with when you start to get worried with SpO2 and other things that you're measuring through the procedure?
It's a good question, actually. As you probably know, when you empty, that's when the saturations often are the lowest. Mm-hmm. And then you get nervous about filling because, now your saturations are low. But as we also know, when you fill, because the blood shunts away from the lung that you're filling, you often get improvement in oxygenation.
Right.
And so, it depends, of course, on the patient, but oftentimes I'll tolerate, a saturation in the mid to low 80s at the end of the section, because I know that once I fill, it's probably going to go back into the high 80s, low 90s. And many of these patients are on oxygen chronically, and so they're probably somewhat acclimated to saturations in the 80s. If it's, gonna go below the 80s, I typically will just stop and ventilate them back up, give them a little bit of PEEP, ventilate them with 2 lungs before I go back and refill.
Yeah, it's always something we keep a close eye on, and it's partially kind of counterintuitive how we have a degree of comfort with emptying and filling, and know the SpO2 is going to kind of improve when we think it's going to get worse, and vice versa. So with these patients that have this procedure done and they tolerate it great, they're going home to wherever that may be, since you have a broad referral base. How are you following up on them? Do you tell them to see you in clinic in a couple of weeks, or just call in and make an appointment when they're short of breath? What's your follow-up plan?
I try to see them within 2 to 4 weeks of getting the lung lavage. I find that patients really do well after the lung lavage, and so oftentimes I'll tell them to follow up with me in 2 to 4 weeks, and I often won't even see them for 3 to 4 months, and they will come back feeling great. Obviously, it depends on the severity of their disease and how quickly their protein reaccumulates. But I typically ask them to see me in 2 to 4 weeks, and then typically I'll order PFTs at that visit for their next visit. But I find that a lot of patients actually kind of get a little bit lost to follow-up simply because they're feeling well. And for the first time, they're able to do X, Y, and Z. And so they feel like they don't need to come to see you until you have your office call them. But yeah, typically 2 to 4 weeks is my time frame.
Sure, yeah, that makes sense. So Tisha, time for closing remarks. Anything you feel we left out that's important to discuss?
No, I think the thing that I would say to the interventional pulmonary community, is that yeah, this disease can be diagnosed with a blood test, and I think that if you do accumulate a patient population because of having to do frequent lavages, you should either find a partner, a pulmonary partner who is really interested in treating these patients, or I think a handful of interventional pulmonologists may also be interested in the therapeutic side of this as well, outside of whole lung lavage. I've been trying to get, people more and more interested, but I think the bottom line is that, the reason that I've stayed in the rare lung disease space, even though I've gotten quite busy in my day job, is that this is a patient population that really needs more awareness and needs more physicians that are experts in their condition, and so I think these patients that you will find, where it took forever to diagnose them, right? Diagnosis in the literature takes over a year for the vast majority of these patients. And so they've been suffering for a long time. I always say if it took over a year to get a diagnosis, almost every patient has either felt or been told that they're crazy in some way, right? That they don't know what they have. This isn't a real thing. I've been trying to treat your asthma. I don't know why it's not getting better. So by the time they get diagnosed, they're actually a little scared and a little lonely. And now they're like, oh, I have a diagnosis. But now they realize that, like, I have a rare diagnosis. I don't know anyone with this diagnosis. The doctors seem not to know about the diagnosis. And so it's the reason that we created the patient-based PAP Foundation, because now the patients can meet others with their condition who have done quite well. And then our goal is to connect the patient community with physicians that actually have some experience and some expertise in PAP. The foundation has been going from site to site to do patient education days and grand rounds and things like that, because I think my ultimate goal is that I want these patients to get diagnosed timely and to be given all the opportunities for whether it's treatment trials or the latest therapeutics, or being able to get a whole lung lavage by someone who's done them before.
Sure.
I have a ton of stories, Samir, from all the years of people getting lung lavages at outside hospitals, from people that had never done the procedure before, watched it on YouTube, and they got a pneumothorax and almost died. There's just a lot of stories when you've been in this space for a long time. And so it's ideal, I think, for patients to be able to get connected with other patients, as well as the physician community that really cares about this patient population.
Yeah, the foundation certainly sounds like a very important endeavor for a group of patients dealing with a diagnosis that I would say a majority of pulmonologists don't come across, or if they do, it's quite rare, outside of a few exceptions, of course. Tisha, that was amazing. I really appreciate the opportunity to pick your brain about this, and I'm sure our learners have learned a ton. Listen to your expertise about this very rare condition. I appreciate your time.
Yeah, no, thanks so much, Samira. I love talking about PAP. I love talking about the rare lung disease space, and so yeah, it's been great to spend some time with you, and please let all the IP community know that we're definitely happy to help if there's any PAP patients that cross our path.
We certainly will. Thank you, Tisha.
All right. Thanks so much, Samir.